Yeah, we're going to be talking about ICU. This is a topic that's very close to me. I've been volunteering in the ICU for 3 years. Been working on some research with some of my colleagues here in the ICU, and I spent my second clinical rotation working a lot in the ICU. So yeah, here we go. So these are some of the numbers in the ICU. There's 5.7 million ICU admissions per year. About 50% of Americans will spend some time in the ICU before they die. 20% of Americans will die in an ICU or shortly thereafter. And this costs $82 billion a year. That's 0.66% of the GDP. So there's some really big numbers in here. Most patients go into the ICU with sepsis, which is a life-threatening infection. And most patients leave the ICU with ICU-acquired weakness. There are two main components to ICU-acquired weakness. First is critical illness polyneuropathy, which you can see here is caused by microvascular ischemia that can lead to axonal degeneration, mitochondrial injury, and sodium channel dysfunction. There is also critical illness myopathy that's also caused by microvascular ischemia that leads to necrosis and catabolism of skeletal muscle. Risk factors include sepsis, multi-organ failure, hyperglycemia, glucocorticoid, neuromuscular blocking agents, and immobility. And we can treat ICU-acquired weakness with early mobilization, which is mobilization within 48 to 72 hours, and the goal is maximal mobilization, ideally ambulation. So those two components are really important, time and ambulation. Benefits of early mobilization include better 90-day mortality and 1-year outcomes, decreased delirium, ventilator days, sedation, ICU length of stay, and it's also cost effective. This picture right here was taken in 1970 when patients were ambulated in the ICU. Since then, they've become heavily sedated and are therefore immobile. But is early mobilization safe? These patients are very sick. The 2018 clinical practice guidelines looked at 12,200 patient cases, out of which there were 15 safety events reported. That's only 0.0012% of cases. And if we take a closer look at these events, none of them were life-threatening. So yes, early mobilization is safe. However, there are barriers to early mobilization, which include lack of staffing and training, unclear goals and responsibilities, poor planning and coordination, and an ICU culture of sedation. And there are also promoters to early mobilization, which is having a mobility champion, staff education, a mobility protocol, and a dedicated PT for the ICU. So the clinical problem, ICU causes irreversible damage, decreasing patients' 90-day mortality and 1-year outcomes. Research shows that early mobilization is safe, cost-effective, and can decrease ICU-acquired weakness, ICU length of stay, and delirium. Despite this evidence, there are still barriers to early mobilization, and there's a gap in the literature on how to best promote early mobilization to change the ICU culture. My primary purpose is to demonstrate strategies for promoting early mobilization in the ICU, and my secondary purpose is to describe mobility outcomes with delayed mobilization. I hope to contribute skills to overcome barriers to early mobilization that can benefit patient outcomes and that can be applied by physical therapists to promote early mobilization across all ICUs. So my patient was a 70-year-old male who presented to the ICU due to sepsis, secondary to bile duct obstruction. He was fully independent and working as a school bus driver, and he had good family support and no financial burden, so he was in pretty good shape. His medical diagnosis included acute renal, liver, and respiratory failure, sepsis, bile duct obstruction, among other diagnoses. And his goal was to return home and be independent. He was admitted to the ICU at day 0 due to sepsis. At day 1, he went into respiratory failure and he was intubated. At day 3, he went into kidney failure and had hemodialysis. And not until day 17, after he had a trach collar placed, was he actually evaluated by physical therapy. I looked and found no evidence of why he couldn't have been evaluated at day 3. At day 20, he was seated at the edge of bed. At day 27, he was transferred to a chair using a big mechanical lift. And finally, at day 42, he was discharged to a long-term acute care hospital. Not a great discharge destination. For the initial exam, I looked at functional mobility and strength. Level of assist is just a measure of how much assistance a patient requires. 1 and 2 times are for 1 and 2 person assists. For his rolling in bed, he required total assist times 2. For supine to seated at edge of bed, he required total assist times 2. Sitting at edge of bed, he required total assist times 2. Basically, he couldn't do anything. I also looked at MMT, which has good intra and intra-rater reliability. A 0 out of 5 is no strength, a 5 out of 5 is 100, 3 out of 5 is 50% strength. And his right bicep was a 3 out of 5, his left was a 2 out of 5, and his right quadricep was a 1 out of 5, and his left was a 2 out of 5. And these tests were not performed in standard position because of all the lines and things that were coming out of him. And all the muscles in the general area were grossly the same as well. So the PT diagnosis, 70-year-old male presents with ICU-acquired weakness and poor cardiovascular endurance, limiting his ability to perform transfers in order to return home. Due to his multi-organ failure, diabetes, prolonged immobility, prolonged mechanical ventilation, and sepsis, his prognosis was poor. However, he did have positive family support. So for his functional mobility goals, I had a short-term goal of max assist times 2 and a long-term goal of moderate assist times 2. And for his core bicep strength, I had a short-term goal of bringing his hand up to his mouth 1 time and long-term of 5 times. For his core quad strength, his short-term goal was to do 30 degrees of knee extension and 90 degrees for his long-term goal. The patient was to be seen by a licensed PT, a DPT student, a respiratory technician, and a nurse for 4-week duration or length of stay at the hospital. Planned once a day, 7 days per week for a total of 28 visits. This was a little ambitious because he was only seen 10 times due to lack of staffing. So, from day 0 to day 17, he had an endotracheal tube and nothing was done. So, once upon a time, endotracheal tubes were actually a contraindication to mobility, but let's be clear that that is not the case anymore, even though some PTs still believe that. And from day 17 to 47, when he had a tracheostomy, we did some in-bed and seated exercises. For his in-bed upper extremity exercises, we did elbow and shoulder flexion and extension. Lower extremity, we did knee flexion and extension with ankle pump, all 10 repetitions to improve his range of motion and strength for his functional mobility. And then for his seated exercises, we did side elbow lean, knee flexion extension, ankle pumps, leg approximation, and sitting endurance, again to improve his strength and range of motion for his functional mobility. So these were his outcomes. Rolling and supine to sit made no improvement. Seated at edge of bed improved 2 grades to a maximal assist. So even though he did improve a little bit, this was not really functional. He couldn't really do much. For his biceps MMT, his right improved 2 grades, his left improved 1+ grade. And yes, this is a detectable change, but you can't really do much with your biceps with a 3 out of 5. You know, he couldn't feed or groom himself or anything like that. So I consider that a non-functional change. And then for his quadriceps, he did improve 2 grades on the right, 2 on the left. This was detectable, but he still couldn't perform any sort of transfers or ambulation or even close to standing. So not a functional improvement. On to the discussion. None of his goals were met. So let's talk about why. I think that there is some organizational and physiological factors that we're going to look at. And for the organizational factors, we're going to look at these four, and we're going to start with delayed physical therapy. So PT started at day 8 is too late and does not improve physical outcomes or discharge destinations when you're working with patients in the ICU. And we're going to see later another study that's going to explain a little bit of why this is happening. My patient wasn't seen until day 17, and by this point, he had really severe ICU-acquired weakness, so he didn't make any improvement. There's this study, Dub et al., that performed a literary search and defined some of the barriers to early mobilization. This is an excellent study. And they found that lack of training, planning, and staffing are all barriers to early mobilization. And the hospital where I was working had no dedicated PT for the ICU. They just had one PT that kind of floated in and out. And that one PT didn't have any specific ICU training, so they didn't know how to work with mechanical ventilators and different ventilator settings. There was poor planning among nurses, RTs, and doctors, no transdisciplinary mobility goals, no PTs on weekends, and no PT aides or PTAs who worked in the ICU. The same study said that an immobility culture and lack of a mobility protocol are also barriers to early mobilization. And the hospital where I worked, I noticed a lack of buy-in from some PTs, nurses, and doctors. So there is a culture of immobility in this ICU. And they had no mobility protocol that you could use to even screen for patients who might be appropriate for mobilization. These are some of the physiological factors that made it difficult for my patient to achieve his goals. So first, poor intervention choice. Okay, early intervention at 30 hours, yes, this is early, of in-bed cycling and electrical stimulation does not improve global muscle strength at discharge. So just because it's early doesn't mean it's going to work. It has to be more functional, higher intensity, right? So these interventions were too low in intensity. And then my patient, as you saw early, only performed in-bed or seated interventions. And a better way to define early mobilization should be early ambulation. This is what happens to the diaphragm after 18 hours of mechanical ventilation. You can see the decrease in the cross-sectional area. Imagine what this would look like at day 17. And this has been shown by many, many studies of how quickly your diaphragm weakens. My patient was never able to wean off the mechanical ventilator at any time during his stay. This is looking in the y-axis, the cross-sectional area of the rectus femoris, and here you can see days. So at day 7, there's a 20% decrease in the cross-sectional area. Imagine what this graph would look like if it went down to day 17. But let's make a point here that this is not your typical muscle atrophy. This is a completely different process. These are some histological slides at day 7, which show necrosis. You can see how the whole kind of muscle cell membrane is just degenerating, and you can see macrophage infiltration right there. And this kind of explains that other study that showed that there were no functional improvements when PT started at day 8, because at that point, this is what the muscle looks like. So again, imagine what this would look like at day 17. These patients are critically ill. There's a lot of inflammation. There's a lot of medication. So this is not your typical atrophy of the muscle. There's a positive side to this, you guys. There's a positive side, I promise. So there were some positive outcomes. I was able to use interprofessional collaboration, multi-professional education, and an ICU mobility protocol to help erode some barriers to early mobilization in the hospital. So I promoted interprofessional collaboration by inviting some of the ICU nurses to visit UCSF and learn about the UCSF mobility program. They were very excited about it, but it didn't end up happening, but I still tried to promote it. And I ended up talking with a mobility champion that had a nurse that wanted to implement a mobility protocol. And we talked about two kind of important points, that when you're starting a mobility program in an ICU, you want to start one patient at a time instead of trying to mobilize all of the patients, and then kind of letting that one patient grow organically throughout the whole ICU. And the other one is to ambulate patients prior to extubation, not after extubation. These patients are very sick and need the ventilator for support. So if you ambulate them when they're on the ventilator, you can actually increase the support so that they can manage. But if you take them off and they're trying to breathe on their own, and then you try to walk them, it's like beating a dead horse. I don't know, it's crazy. So you gotta walk them before they get extubated. The ICU nurse manager invited me to present to the ICU nursing staff, and my presentation focused on two key protocols. One is the 2018 clinical practice guidelines, and another one is the guidelines for mobilizing ventilated patients. So 23 experts developed a mobility protocol to mobilize ventilated patients. They come up with a green, yellow, and red light system for different parameters. It's important to note that red does not mean stop, it just means be careful and look at the whole patient and consult with the whole clinical team. And a very important conclusion is that vasopressors and mechanical ventilations are not a contraindication to mobility. This is very important. If you guys are going to remember anything, just remember this as you go into your future clinical rotations. This is the 2018 clinical practice guidelines published by the Society of Critical Care Medicine, and they provide parameters, cardiovascular, respiratory, and neurological parameters. We're not going to go into details of these parameters, but to help you kind of screen for which patients might be appropriate for mobilization in the ICU. And they also came to the same conclusion that vasopressors and mechanical ventilations are not a contraindication to mobility. If you're going to remember anything, remember that. So the nurse manager ended up adopting these protocols that I presented, and the ICU team was educated on them. And these new guidelines were posted outside of the ICU room. This is a picture that my CI sent me. This is that same guideline that I just showed you. So, success, yeah. So, even though the patient didn't really get better, some changes did happen in the ICU that will hopefully promote that more patients will get the care that they need and that they deserve. So my initial exam definitely lacked detail. I could have used the MRCSS, which looks at 12 muscle groups, and less than 48 out of 60 is diagnostic for ICU-acquired weakness. So lessons learned: delayed mobilization leads to irreversible ICU-acquired weakness with poor physical outcomes and poor discharge destinations. Many ICUs have a culture of immobility and don't provide early mobilization. Early mobilization requires collaboration, education, mobility protocols, and a culture change in the ICU. And I believe that PTs have the responsibility to skillfully change the culture of the ICU so we can save lives and decrease healthcare costs. Future work, informatics. So informatics can be used to collect, analyze, and visualize data from electronic health records. And this can be used for many, many things, but specifically I want to talk about how this can be used to validate the ICU mobility score, because we can use informatics to get inter and intra-rater reliability, ceiling and floor effects, and feasibility. So why is this important? The problem is that the current ICU mobility scale, which is widely used, is based on levels of assist, but when you're working with these patients in the ICU, you have to manage equipment that's attached to the patient, which inherently introduces bias into the score, and it also can't measure high-functioning ambulatory patients. The solution is the ICU mobility score that was developed here at UCSF by Heidi Engel and some other people. And this is based on ambulation distance and can measure both low functioning and high functioning patients that can ambulate any distance, and can be used across the entire hospital. And most importantly, it helps redefine early mobilization as an intervention that includes ambulation. So my conclusion is ICU-acquired weakness causes necrosis that increases mortality and decreases functional outcomes. There's strong evidence that early mobilization is safe, feasible, and beneficial to patients. However, cultural barriers still prevent implementation of early mobilization. PTs must tactfully change the ICU culture through education, transdisciplinary collaboration, and promotion of evidence-based mobility protocols. And there's a very large and very sick patient population out there, guys, that needs our care and needs a change in the mobility culture towards mobility. I would like to thank all these wonderful people. And are there any questions?
Great presentation. Sorry if I missed it, but did you mention OT at all? And was there any referrals to having OT in the ICU as well?
I know that at UCSF, OT kind of works in the ICU. I didn't see it at this hospital where I work, so no, there was no.
We have one OT in every ICU.
Yeah.
Great presentation. I just wanted to clarify something that you said earlier. You said that when it comes to ambulating patients, that it's better to do one at a time versus like multiple patients at a time, correct?
Yeah.
And then if that's the case, because you also mentioned, I believe earlier, that there's that time frame, if patients start ambulating 8 days after, then the outcome of how they'll mobilize later is poor. So in terms of the idea that you were thinking, how would you make sure that every patient on the floor in the ICU will be able to ambulate, or how would that be organized?
Yeah, that's a really good question. And I think every patient in the ICU should be mobilized if they're appropriate. I think what I was referring to is that when you're starting to try to make these big changes in an ICU where you have all these doctors and nurses and PTs that have been working there forever and they're stuck in that immobility culture, if you try to go in and say, hey, okay, all the patients up, they're gonna look at you and you're gonna get so much pushback. So the point is that in order to establish this new culture and these new protocols, you wanna start just one patient at a time so that different people can begin to see it's like, oh wow, that patient's getting better. Or like, oh wow, look at that patient, they're walking, they're intubated. Like, maybe it's not so scary after all. And then you slowly begin to convince people that mobility is a solution to the problem in the ICU. And then eventually all the patients are mobilized. And that comes out of a study by Ely in 2016. Yeah.
I had a question, when you were talking about kind of that you couldn't quite reach the intensity needed with the exercises you did, and you looking back, wish you could have changed that kind of or fixed that as a limitation, what would you have suggested then in the ICU, maybe as their X or as, adjusting sitting tolerance to add it to be more intense?
That's a good question. I think when you're working with patients in the ICU, it's very complicated because they're just amidst this huge critical illness. So they have delirium and all these other complications. And really ambulation is the best intervention, or getting them as close to ambulation as you can, because you need those mechanoreceptors in the joint, you need the vestibular system to get challenged. You need to wake them up this is another really important point, in order to ambulate them, they have to turn off sedation. So just by having the goal to ambulate, there's all these other things that need to happen that are also really beneficial for the patient. So I think that's really the goal, and these patients are not trying to get fit. They're trying to go home. And what's the number one thing that you need in order to go home and discharge from the hospital? It's ambulation. So why would you do anything else? Of course, if they have some sort of complication, you can try to come up with something else, but I think that's kind of the best goal to have. And there's some other presentations also showed the Sarah study, which is kind of like a halfway point to getting them towards ambulation, or there's also the tilt tables where they're laying down and then you slowly bring them towards standing and weight bearing, also for bone health and a bunch of other reasons. Yeah.
Can I just say one thing?
So this is Heidi Engel, and I'd also like to make a plug. Heidi Engel is teaching the 199 ICU elective. So if this is interesting to you guys should work with her. She's a wonderful, wonderful mentor, and she actually started the UCSF mobility protocol at the ICU here. She's won prizes for research, and she's great. Go ahead.
Thanks. This is a story of medical mismanagement, right? So this entire story, this case that he presented, unfortunately, is standard of care in most places. Only about 1/3 of ICUs across the United States have an ICU early mobility protocol. As PTs, you will get sent there without being trained to know what to do there, unfortunately. People think you will magically know what to do with the patients, but it's a multidisciplinary process, just like Mariano pointed out. Sedation has a large impact as to why you would not have gotten in there earlier. The thing is that this man's problems were caused by us. So make no mistake about it, he didn't just happen to become so weak that he ended up not being able to wean the ventilator and not be able to go home. We created the mess he became. When I say we, I mean the way he was medically managed, but also our profession. It is our profession's lack of advocating for the better health of our patients that has prevented this from becoming standard care. Just like Mariano said, optimal care would have been day 3, you'd be in there standing him up, orienting him to reality, no sedation on, turning up the ventilator so the work of breathing was not interfering with his ability to use his skeletal muscle. Skeletal muscle is a very key organ system. It is part of your immune system. So your survival often depends on a well-preserved skeletal muscle system, which he apparently had when he first got sick with something that isn't that big a deal. He stopped being critically ill 5 to 7 days within his case and then turned into a chronic patient with a lot of complications as a result of lying in bed, being over-medicated. This means his problems were iatrogenic. And so the struggle is, how do we in our profession advocate for our patients so that we don't create these patients anymore? Because the doctor is just there to eliminate the disease. But we're supposed to be the ones that are there to maintain skeletal muscle, to bring folks back to the quality of life they had before they entered the hospital. So this is a responsibility you can take on. And I think Mariano did an incredible job as just a student trying to advocate well for this patient. And, you know, it's not easy.
And you guys can too.
And you can too. That's it.
Make a difference.